And thank you to Vitrolife for inviting me to the symposium, but also to be able to come back to Finland and to Helsinki. It's literally a very bright opportunity to be here during this time. And welcome to you all. So I've been asked to address this particular topic this morning, but I think you'll agree that we are living in very exciting times where we are trying very hard to understand the embryos that we see before us, and we know that they're not equal. They're not all equal, so therefore we have to do an aspect of selection. I think we've just heard a really wonderful talk from Marcus, and particularly the comment about there is no room for compromise. And I think that is very true in moving forward in everything we do in the field of reproduction and IVF in particular. And we spent the last 4 decades trying to understand what is going on in the embryo and trying to distinguish factors that will help us decide what is an embryo that is viable and one that may be less viable than another. And even in 2011, we had this Istanbul consensus looking at these various things. And yet, what is this telling us? This is telling us a snapshot of a moment in time. This was all based on elements that we get from maybe a 2-minute observation, if that, on a single day. And we're moving on from that because we know the whole process and the information we get from these processes is dynamic. So we now have high-tech options. And what are those high-tech options? Well, we have pre-implantation genetic screening. We can potentially still use the polar bodies or the embryo. We can use different technologies in that, moving on to the NGS technologies and carrier mapping. And we're also trying to look at the blastocelic fluid to see if that gives us information. And then we have, as we well know, we have time-lapse technologies. And they're giving us different algorithms, different informatics, doing different used differently in different laboratories. So again, there has to be an understanding of a consistent approach to the use of these technologies. And we could combine time-lapse and PGS, which is what I'm going to talk about, to some extent, but that's not everything. There are proteomic issues, there are metabolomics, and may well be that mitochondria need to be looked at some stage too. So there's a vast amount of information, and it's up to us to try to find the signal in the noise, the signal that will give us the opportunity to understand the embryo that can and hopefully will make that baby. So I'm just going to focus on PGS and time-lapse during this talk. And I'm going to first of all just do an overview looking at the Downs-Black scoring system. This is most of you will probably know, it's a healthcare scoring system that uses a raft of publications in trying to understand where we are at a moment in time with the information available. And this was published by Lee and colleagues in 2014 on 19 observational studies. But only a few of them were RCTs that were scored highly, and the rest were scored moderately in terms of 14 observational studies. And what they showed was there are still main weaknesses in the work that's being done in this field. There's lack of randomization. There is failure to analyze the data according to intention to treat principles. Now, again, we tend to have a difference. It's per cycle started in the UK, it's intention to treat in the US. But some would argue in any event, we really ought to be looking only at embryo transfer. But there is an importance in a lot of what we're seeing in that there's a failure to control for confounding variables. And we've seen this in our own analysis of thousands of data. It's extremely important to do this, and especially regarding to the study design. It's whether the numbers of embryos transferred have been taken into account, for example, something as basic as that. But the overall conclusion was that the RCTs did demonstrate a benefit in terms of increased implantation and pregnancy rates and a decrease in miscarriage when using the time-lapse systems. So, oops, gone the wrong way. Okay. So let us have a look at these time-lapse imaging systems. What can they do for us? Well, we know that we can have a look at the morphodynamics, and so we can look at things in the cytoplasm, and we can look at things extracytoplasmic. And we list the variable opportunities here that we can look at, and we can study dynamically, and we can go back and study them, which is really very important. But also, we can also look at the morphokinetics, which is also extremely valuable. And there are a raft of opportunities here, as you can see, during the progression of the embryo development. You can choose a whole range of different criteria that one can look at in terms of various cell stages, the duration of those cell stages, the dynamics of them, such as the issues that the opportunities I list here, pronuclei, compaction, blastulation, etc., etc. So we have dynamics, and we have the timing of those dynamics. And Campbell produced a really definitive, Campbell and colleagues, definitive couple of papers back in 2014, using some algorithms, and basically the algorithm, as you can see here, was the start of blastulation plotted against the time to complete blastulation, and it really looked at the opportunity for implantation. So this was data where you knew that the outcome of the embryo, where it had a clinical implantation of fetal heart or it didn't. And you can see here that the particular time point here in this bottom left-hand box resulted in most of the embryos, or giving the highest chance of embryos to implant, whereas over in this area here, where the embryo was developing later, there was a much lower chance and incidence of implantation, suggesting that actually you could have an algorithm related to a temporal event that indicated the viability of the embryo. And this was then plugged into a raft of data from 27 clinics showing a similar type of curve as we see there. But there was another study done by Rienzi and her colleagues in 2015 that showed no correlation whatsoever between euploid, which were the green, and aneuploid, which were the blue embryos, as you can see here. And this was the detail of the study. However, this was on poor prognosis patients, and there was another study done by Basile and colleagues who actually showed there was a difference. So again, very clear, and the previous speaker highlighted this very effectively. It's all about the consistency of the conditions that we're looking at, from the patient to what is going on in the laboratory to the types of systems you use. And then when one is looking at ploidy data, what type of ploidy? Are they single aneuploidies, or are they complex aneuploidies that we're comparing? So at the moment, there is some disagreement about what can be measured accurately with time-lapse, but irrespective, what we can get to is a consistent approach as long as our parameters are measuring, as we say, apples with apples or oranges with oranges. So I want to take you through now our fertility data. And this data is based on live birth outcome only. We sometimes use the acronym KID embryos, KID embryos, known implantation data embryos. This data is all based on live birth outcome. And you can have a look at the left-hand side of the parameters that we looked at. Highly detailed parameters from 24,000 records, which even included, if we had any recipient cycles, the age of the donor was taken into account. And fundamentally, what we had was 21,379 standard incubation treatments, 2,500 plus embryoscope, that's our time-lapse system, treatments, and we had nearly 15,000 unique patients. We did have a recipient category, which we've accounted for, and as I've mentioned here, with a donor age, and then we divided the data for simplicity, especially for the talk here, just to less than 38 age group and those that are over 37. And what did we find? Well, we first of all used our CareMaps program. And we call CareMaps this acronym because it defines everything that is done in all our multiple laboratories right across the group. Huge consistency, enormous quality control, vital for being able to analyze the data as a complex. So MAPS for us was simply a morphokinetic algorithm to predict success. But everybody in the organization knows exactly how to annotate, and the quality control across those annotations is extremely accurate. And this has been an iterative process, looking at a whole raft of various opportunities to look at this dynamic period over the 5 days of cleavage, and various time points were taken. And we arrive and we continue to evolve our particular algorithms. And as I've said before, you can only do this work if you know the outcome of the embryo transferred. A singleton must produce a singleton live birth. If it's a double embryo transfer, you must have 2 non-identical live births in order to know exactly what that embryo has done, to compute the data for live birth rates. So what did we find? And this is based on, these are the 2 publications from Allison, and they were nominated in the 2013 Robert Edwards Award. So what we found, we have over 1,000 delivery. Now these are delivery events. They're not deliveries. They are actual deliveries, not babies. So in other words, if it's 2 babies, it's 1 delivery, and there's 1,007 of those deliveries against 6,000 standard incubations. And we can see here the age of those that were having embryoscope or care-maps was 36.9, considerably older than the standard incubation group of 35.3. And yet in most of the parameters that we look at in terms of positive chemical pregnancy, fetal heart, implantations, a live birth event, and babies per embryo transfer, there was a highly significant difference for the care-maps group versus the standard incubation group. And again, I emphasize taking every single parameter we could into account on the patient factor 2. So if we were just to look at the blastocyst versus our overall data, what we actually found, again, significant differences, but with a 25% uplift if we were going to blastocyst, and a 20% uplift overall using our care-maps algorithms. So we looked at the data a little bit more in depth, and I found this very, very intriguing. What we discovered was that if we put a single embryo back at the blastocyst stage, and we compared that to standard and, of course, the care-maps embryoscope, we did get that significant rise, as I showed you, but because you're putting a single back, you're not going to get any multiple pregnancies. But what really did surprise us is we actually got a still significantly better live birth rate than putting 2 back from standard incubation, 2 blastocysts back from standard incubation. But if you put 2 blastocysts back from standard incubation, you have a massive leap in multiple birth rates, which of course is something we really want to avoid. So in any event, the single embryo, it wasn't compromising against 2 embryos from the standard group. So there was no reason for us to put 2 back at all, as long as we were using the care-maps algorithms. Now that's one thing, but of course you're not just getting the morphokinetic information, you're getting visual information. And here we see this thing called reverse cleavage. A 2-cell, if you look at the time points here, reverses back around nearly 30 hours back to a single cell. Now, you would not see that kind of dysmorphic variant during cleavage with a single observation. And in our atlas here, we describe many of those anomalies that we see during cleavage that are only available with time-lapse, and the only opportunity available to go back and look to see what happened to an embryo is again through time-lapse imaging. This is why I think also it's been a very powerful tool. So what is our approach? Our approach is that we believe using time-lapse is a safe and secure system for incubation, not least because of what we've just heard from the previous speaker. I also like the fact that it gives time to analyze all the cleavage patterns and temporal relationships, because the embryologist can go back and look and look and look again. It's the opportunity to discover the anomalies that I've just spoken about. We have a hierarchical selection of embryos, and we do believe there is strong evidence for improvements in live birth rates. So our clinical decisions now are that we will discuss it with all patients. We'll recommend it for sure to those with failed IVF or miscarriage, but we don't believe it is a replacement for any form of ploidy PGS testing. If we really want to get the ploidy information, you have to do PGS. So let's just finish off by looking at time-lapse and PGS. There's really only one study, and it's a prospective randomized controlled trial using sibling oocytes from Yang and colleagues, 2014. And they used competent blastocysts for transfer by combining time-lapse and array CGH. And what did they find? Well, interestingly, in their study, they didn't find any morphokinetic differences between euploid and aneuploid embryos. But what they did find is if they combined PGS and time-lapse, there was a significant increase in the outcome in terms of clinical pregnancy rate and in implantation rate. So by the combination of time-lapse and PGS in this prospective sibling study, it was advantageous. So in summary, I would say time-lapse gives us the power of imaging, maybe up to 300 different opportunities to have a look at that embryo per day without any stress on the embryo at all, and the opportunity for algorithms. What is the embryo doing at any particular moment in time, and how can we get algorithms that allow us to understand viability? We have to understand the conditions in which we work, as has already been stressed, and any patient effects too. We have to do appropriate analyses. We have to have appropriate quality management, quality assurance procedures in place for everything we do, but even particularly for annotation if you're using time-lapse. And the outcome measures are important. We decided to stick to live birth rate because that was the only outcome, the outcome measurement that we really wanted to understand. And we can look very importantly at whatever else happens, we can discriminate between dysmorphic cleavage, which is very important. And there are, I believe now, studies giving strong evidence for increased live birth rates. But what about PGS itself? We believe we now have the technology to give high-fidelity information with PGS, so that is important, although mosaicism is still an issue and it needs further debate. PGS will help to avoid the transfer of aneuploid embryos, and David mentioned that very early on in the session. It's very important for us, it's a clinical imperative, to try to avoid the transfer of something that can do harm, and at best just not allow pregnancy to occur. And PGS is better than random selection at doing that. There is no argument. We get better results if we use blastocyst. It's a prognosticator for outcome. But we also believe that blastocyst plus ploidy now is still giving us much higher live birth rates. So there is some evidence to support increased live birth rate and reduce multiple births and lower miscarriage with PGS. So in conclusion, there's one prospective RCT using sibling oocytes to support combined time-lapse and PGS. Let's not forget, euploid embryos may still have metabolomic and genomic dysfunction. So that will affect the morphokinetic cleavage patterns, irrespective of what the ploidy is. So it's very important that we understand that. And given the observed morphokinetic dysmorphism of embryos and the often unrelated level of aneuploidy, there is an argument that these are complementary techniques. And I definitely believe they are. So just to finish off, one final point, not necessarily related to the science, is this is this is an embryo that resulted in JC, a little girl. And why I'm showing you this is this actually now is something that hundreds and thousands of our patients are doing. And here we can see JC at 3 months, JC 8 months from fertilization. They are downloading the images from the embryoscope through our network of the embryo that went back and the embryo that made their baby. So they're using this system. We use it scientifically. They're using it to start their photographic album. Thank you.